So we are 12:01. Welcome to Grand Rounds, everybody. I'm sorry I'm a minute late. It's a pleasure to introduce Dr. Drury, one of our new staff who's just joined us in the Division of General Internal Medicine with a special interest in thrombosis. Dr. Drury's been in our program for the last 5 years, completing his core internal medicine and then subsequently his fellowship here in medicine. He also took training in Ottawa and complemented by training here for his thrombosis component. Dr. Drury was a UBC member previously, has done its master's disease in experimental medicine, an accomplished physician, and we welcome him today to talk about, as you can see, COVID-19 and venous thromboembolism. Taylor.
Thank you, Dr. Casson. It's certainly an honor to present here at St. Paul's Grand Rounds, my first ever, hopefully not the last. We have a lot to cover, so hoping to get started. As Dr. Casson alluded to, today we're going to be talking about COVID-19 and venous thromboembolism, the BC experience, and review of the current evidence. So I have no disclosures. The objectives today are to review the incidence of VT in hospitalized patients with COVID-19, to introduce the caveat study and review preliminary results, and then lastly to review the current evidence for thromboprophylaxis in hospitalized COVID-19 patients. So as we all know, COVID infection is associated with a profound inflammatory response within the lungs and other organs. The virus directly infects endothelial cells, causing inflammation and dysfunction, as well as a huge surge in inflammatory cytokines, resulting in a profound acute phase response. And this results in a number of disturbances, including increased thrombin generation, deposition of fibrin in the lungs, increased fibrinolysis, and subsequent marked D-dimer elevation, and extensive platelet activation and microvascular thrombosis. And together, this hypercoagulable state, plus the immobility and critical illness status that comes with patients infected with severe COVID, places these patients at very high risk of thrombotic complications. And this was borne out in the early COVID literature. Early data from China in April 2020 found that 25% of patients admitted to the ICU were diagnosed with venous thromboembolism, and nearly 50% of these patients died. Concurrently, early data from Europe around the same time in April of 2020 found that 27% of patients in the ICU were diagnosed with venous clots, despite routine standard thromboprophylaxis, and 13% of these patients died. And a meta-analysis published a few months later, including a larger cohort of 33,000 patients, again found similarly increased diagnoses of venous thromboembolism in the ICU, and nearly 8% in patients admitted to the ward. And so all of this was markedly higher than previously reported incidence of VTE in hospitalized patients while receiving DVT prophylaxis, which in a number of large earlier studies is found to be about 1% in hospitalized ward patients and up to 10% in hospitalized ICU patients. So accordingly, there was a lot of concern early on in the COVID pandemic that the COVID-19 infection was associated with a far higher rate of venous thromboembolism than previous infectious diseases, and begged the question that perhaps higher intensity thromboprophylaxis is required in these patients. And early in the pandemic, the BC CDC recommended using enoxaparin 30 milligrams BID, which qualifies as intermediate dose anticoagulation for thromboprophylaxis in patients admitted to hospital with COVID. Based on these high reported rates of venous and arterial clots, and following a pilot feasibility study, Drs. Tony Wan and Agnes Lee submitted a grant proposal to the BCH Research Institute for the creation of the caveat study, which is entitled COVID-19 Associated Venous and Arterial Thromboembolism. And this is a large collaborative effort between the St. Paul's Hospital Thrombosis Service, VGH Hematology, VGH ICU, VGH CTU, VGH Stroke and Neurology Services, as well as VGH Cardiology. We had initially involved members from Fraser Health, but unfortunately they were unable to carry on due to their increased COVID-19 workload. We were fortunate enough to receive $35,000 from the VCH Research Institute in May 2020 and enlisted chaos for creation of a REDCap database and ongoing statistical support. And eventually we were provided with a list of all patients with a COVID-19 positive swab admitted to a Vancouver Coastal Health Hospital from January 2020 to December 2020. And thus the caveat study was born. And this was a population-based retrospective cohort study using available health records in BC. We included all patients admitted to a Vancouver Coastal Health Hospital who were swab positive for COVID between January and December 2020. And these included St. Paul's Hospital, Mount St. Joseph's Hospital, VGH, Lionsgate Hospital, and Richmond Hospital. The charts were reviewed in detail, and the following information were collected and recorded in the REDCap database by trained personnel. We collected patient demographic and baseline medical details, daily laboratory results and anticoagulation use, as well as VT and bleeding outcomes, which were then reviewed and adjudicated by senior medical personnel. Post-discharge data for a minimum of 3 months was primarily derived from patients who were seen in the COVID-19 recovery clinics. The overall outcome measures for our study were to estimate the incidence of venous and arterial thromboembolism during hospital admission, to identify clinical and laboratory markers potentially associated with venous and arterial thromboembolism, and determine the risk of venous and arterial thromboembolism in the post-discharge period up to 90 days. And so currently the laboratory data analysis is still in the works. And so for today's presentation, we're going to focus on the data on venous thromboembolism during hospitalization and discharge. Before we move on, I wanted to acknowledge the incredible contributions of our caveat team, led here, as you can see, by Tony Nagy. Our team included, and intentionally in no particular order, Ben Lai, Jack Wan, Gurjeet Bangu, Chris Lee, Navneet Singh, Dominic Manhouse, Gary Misselbrook, Ala Alzaki, Maeve Conroy, Lauren Eddy, and Div Kumar. So thank you to everyone for their many months of hard work. Overall, we reviewed 849 charts. After removing duplicate patients and patients not admitted with symptomatic COVID, our study population included a total of 565 patients. As you can see in the table here, the majority were admitted at VGH or here at St. Paul's, with varying amounts from Lionsgate, Richmond, and Mount St. Joseph's. This is our table 1 of baseline patient demographics. The mean age of patients admitted to a Vancouver Coastal Health Hospital in BC for COVID-19 was 63 years of age. The majority were male at nearly 60%, and the comorbidities listed here are ones that we pre-selected in advance to track as they are most associated with venous thromboembolism, arterial events, and increased mortality. Overall, there was a small number of patients with a prior history of venous clots. There was a small number with active cancer. Just under 10% had a prior diagnosis of AFib or flutter. But there was a relatively high percentage of patients with standard cardiovascular risk factors, hypertension, diabetes, dyslipidemia, and 17% with pre-existing lung disease. Of note, though, almost a quarter of the patients, about 24%, had none of these pre-existing comorbidities and were otherwise relatively healthy. I think overall, this patient population is quite representative of patients routinely admitted to internal medicine, perhaps slightly healthier. Looking at their home medications, again, these were all pre-selected medications that we were interested in. Just under 10% were on anticoagulation at home, and 16% were on antiplatelets. A large percentage of patients were on either an ACE, an ARB, or an ARNI, as well as a statin, as you'd expect from looking at their associated comorbidities. And again, almost half, about 44% of patients were on none of these medications, perhaps reflecting the slightly healthier patient population. The average length of admission to hospital was 9 days, with a large range between 1 and 131 days. Nearly 70% of patients did not require ICU care and thus remained on the ward for the duration of their hospital stay. 30% of patients did need ICU level care at some point during their hospitalization, with the majority of these patients, about 21%, requiring ICU within the first 48 hours of admission. Oxygen requirements are listed here and are representative of the highest level of oxygen support required during hospital admission. The vast majority were either on nasal prongs, about 46%, or no oxygen at all, 36%. 10% were on Optiflow or high flow nasal prongs, and about 7% were mechanically ventilated. This table shows the use of anticoagulation while in hospital. Again, this is reported as the highest intensity of anticoagulation required while admitted to hospital. About 10% were receiving 10% received therapeutic anticoagulation throughout hospitalization, usually therapeutic enoxaparin or a DOAC. About 80% of patients received thromboprophylactic anticoagulation, with the majority receiving enoxaparin 30 milligrams BID, which is intermediate dosed, and as we will remind ourselves, was the intensity of thromboprophylaxis recommended by the BC CDC early in the pandemic. The remainder of patients received primarily low-dose thromboprophylaxis with enoxaparin 40 milligrams daily. I will note that you can see at the bottom of the table, 8% of the patients did not receive any thromboprophylaxis in hospital, which is certainly higher than we expected and a bit of a surprise. Looking at outcomes, overall, 79 patients or 14% of our study population died during their admission to hospital for COVID. Of the 178 patients who needed admission to ICU, 18.5% of them died. And of the 387 patients who did not require ICU and were thus on the ward, almost 12% of them died. The overall rate of VTE across the entire study population was 4.4%, about 25 patients, and most of them were pulmonary emboli. The rates of major bleeding were about 5% in total. There were no fatal bleeds. We had 5 critical site bleeds with 4 intracranial hemorrhages and 1 retroperitoneal bleed, and 26 major bleeds that resulted in either a hemoglobin drop of more than 20 points or that required a transfusion of more than 2 units of packed red blood cells. If we focus in on the VTE outcomes that occurred during hospitalization, again, there were 25 total patients for a 4.4%. A third of them were diagnosed within 1 day of admission to hospital and therefore would not have been impacted by the intensity of in-hospital thromboprophylaxis. In addition, another third of VTEs were diagnosed more than 2 weeks since hospitalization. If we look at VTEs by level of hospital care, as one would anticipate, we can see that the vast majority of VTEs were diagnosed in patients who required ICU care, or thus obviously sicker patients, with only 6 VTEs diagnosed in patients admitted to the ward. Important to note that at the bottom of the table here, of the small percentage who were on therapeutic anticoagulation while in hospital, none of them developed venous thromboembolism, whereas about 60% of the VTEs occurred in patients who were on prophylactic anticoagulation and 8% occurred in patients who were on no anticoagulation. Our chart reviewed also captured the number of patients with suspected PE and as well as the results of their diagnostic workup. You can see in the flow chart here that a total of 154 patients had a suspected PE documented. 150 of these patients went on to have a subsequent scan, almost always a CTPE, and 14 of them were diagnosed with pulmonary embolism. The diagnostic yield of patients in this setting sent for lung scan is therefore about 9.3%. By comparison, in 2 recent studies of PE diagnosis in patients presenting to the emergency department with suspected PE, the PEG-ED study and the YEAR study, they had diagnostic yields of 7.4 and 13% respectively. We certainly know that the incidence of VTE in general in patients who are admitted to hospital is higher than that in outpatients. So to have a diagnostic yield that is similar to outpatients suggests that we physicians in BC were not underscanning COVID-19 patients with suspected pulmonary embolism. If we look at DVTs, there were 30 suspected DVT events documented, 29 of which went on for leg ultrasound, and 9 of which were positive for DVT, yielding a diagnostic yield of 31% for leg ultrasound. Again, if we compare this to the data on patients presenting to the emergency department, recent studies have shown a positive scan rate of 11%. Again, given that venous thromboembolisms are more common in hospitalized patients, the fact that we found a diagnostic yield that is markedly higher than in outpatients suggests that we were not doing enough leg ultrasounds in hospitalized patients with COVID-19. Looking at post-discharge data, there were 486 patients who were discharged from hospital by the time of study completion. Of these patients who were discharged, 18% were unfortunately lost to follow-up. We therefore have good data on 395 of them, or 81% of those who were discharged from hospital. The average length of follow-up was 163 days. with a wide range from 3 to 600 days. Of the patients with follow-up data, 78% of them had more than 90 days of follow-up, whereas 21% had less than 90 days. Overall, the post-discharge rate of VTE within 90 days was 1.3%, which is comparable to previous studies of COVID-19 post-discharge. And so overall, this caveat study included 565 patients admitted to a Vancouver Coastal Health Hospital with symptomatic COVID-19 infection from January to December 2020. So certainly capturing the early phase of the pandemic. Again, 31% were needed the ICU and about 70% were ward level care only. The majority were on appropriate thromboprophylaxis, with 40% on the intermediate dose enoxaparin 30 milligrams BID and 25% on standard low dose thromboprophylaxis. And surprisingly, 8% were on no thromboprophylaxis at all. 14% of them died, with a higher percentage of those admitted to ICU. And 4% of patients were diagnosed with venous thromboembolism, with more than 3/4 of that occurring in patients who were admitted to the ICU, compared to 25% patients who were admitted to the ward. Overall major bleeding rate was 4.6%, and the incidence of post-discharge VTE within 90 days was 1.3%. The next part of this presentation, we're going to talk about the data surrounding the optimal thromboprophylaxis in patients hospitalized with COVID-19 infection. And at the end, we can reflect on how our numbers compare to the numbers in these trials. In this not-to-scale timeline of events since the start of the pandemic, we can see that soon after the initial reports highlighting the high rate of venous thromboembolism and mortality in COVID-19 patients, that we briefly reviewed at the start of this presentation, the global randomized controlled trial machine kicked into gear in the spring of 2020. And since then, in the span of just over 1 year, we've had an impressive 5 major randomized controlled trials published in leading medical journals to address the question of what type and intensity of thromboprophylaxis is best used in these patients. And over the next several slides, we'll briefly discuss these studies in chronological order. The first study was the Inspiration trial, which was the first major randomized controlled trial published, and it was published in JAMA in March of 2020. It included hospitalized patients admitted to the ICU within 7 days of initial hospitalization at multiple centers in Iran between July 2020 and November 2020. They excluded patients at high risk of bleeding, deemed to be platelets less than 50, major bleed within 30 days or active bleeding, recent ischemic stroke, head injury, major trauma, fairly common high-risk bleeding risk factors. They compared intermediate dose anticoagulation, which was enoxaparin 1 milligram per kilogram daily, versus standard low-dose prophylactic anticoagulation, which was enoxaparin 40 milligrams daily. Both of these treatments were continued for 30 days, regardless of discharge. Their primary efficacy outcome was a composite of venous and arterial thrombosis, use of ECMO, and all-cause mortality at 30 days. And their primary safety outcome was major bleeding and clinically relevant non-major bleeding. They included a total of 562 patients, about 280 in each group. They were average age 62, and they were mostly male. They were not an overly comorbid patient group with primarily hypertension, diabetes, and dyslipidemia. And we can see in the middle table that they were indeed ICU patients, as 20% of them were intubated and 30% were on BiPAP. And of note, they were also on good concurrent COVID-19 treatments, with 95% on steroids and 80% on antiviral therapy. Just over 80% of the patients in each group had an 80% adherence to their assigned treatment regimen, meaning that around 20% of patients randomized to the treatment arm of intermediate dose anticoagulation did not actually receive it. Overall, they found no difference in their primary outcome of a composite of venous or arterial thrombosis, use of ECMO, and all-cause mortality. The individual components of this primary outcome were also not similar between groups, with an all-cause mortality quite high at about 40% in each group, and a rate of venous thromboembolism quite low at 3% in each group. If we look at bleeding, there was a numerically higher rate of major bleeding with the intermediate dose anticoagulation, and a similar pattern with clinically relevant non-major bleeding, but neither difference was statistically significant, and overall the bleeding rates were quite low. The next trial was the ACTION trial, published in Lancet in June 2021. And this looked at hospitalized patients in Brazil with an elevated D-dimer from June 2020 to February 2021. They had a similar exclusion criteria, and you'll see as we move through these trials that the overall exclusion criteria is very consistent. This study was different in that it compared therapeutic anticoagulation for 30 days, regardless of discharge, and they used rivaroxaban 20 milligrams daily if patients were clinically stable, i.e. non-ICU, or enoxaparin 1 milligram per kilogram BID if they were clinically unstable in the ICU, and all patients were transitioned to rivaroxaban when they stabilized. And they compared this against standard low-dose prophylactic anticoagulation. Their primary outcome was time to death, duration of hospitalization, and duration of supplemental oxygen at 30 days. And again, their safety outcome was major bleeding and clinically relevant non-major bleeding. This was a slightly bigger trial with 615 patients, 300 in each group. Their comorbidity rate was fairly low, otherwise a fairly healthy population. And almost all of them, 95%, were stable ward patients. 3/4 of them needed oxygen support, mainly by nasal cannula. If you look at the actual study drug assignment, 90% of these patients in the therapeutic anticoagulation group received rivaroxaban, and 84% of the patients in the prophylactic group received enoxaparin. Therefore, this trial is effectively a therapeutic rivaroxaban versus prophylactic enoxaparin trial, and both groups had excellent treatment adherence at over 95%. The primary outcome, a composite of time to death, duration of hospitalization, and oxygen-free days, was analyzed using the hierarchical win ratio method and was not different between groups. They found numerically better outcomes with the prophylactic group than with therapeutic rivaroxaban, but it was not statistically different. And if we look at the primary outcome broken down by its individual components on the bottom graph, we can again see that it was slightly better with prophylactic enoxaparin, but overall not significantly different. They also found no difference in the composite thrombotic outcome, including venous thromboembolism, MI, stroke, and limb ischemia, with venous thromboembolism occurring in about 4 to 6% of patients. Overall, they had 10% of patients in each group die. In terms of bleeding, there was a significant increase in major bleeding and clinically relevant non-major bleeding in the rivaroxaban arm. The next two studies were two publications that came out of an impressive collaboration of 3 major randomized control trials that together combined their protocols and data to help expedite the research process. And these were made up of the ATTACK trial, the Active 4A trial, and the REMAP-CAP trial. They divided their study into 2 manuscripts, one focusing on the top here on critically ill ICU patients and the other on non-critically ill ward patients. Both were published in New England Journal of Medicine in August 2021. And together, these are often referred to as the multi-platform trials. The first one we'll look at was in the non-critically ill ward patients. And so this included hospitalized patients across 121 sites in 9 different countries who did not require ICU level care. And they defined ICU level care as requiring high flow nasal prongs, BiPAP, invasive ventilation, or pressors or inotropes. And this study ran from April 2020 to January 2021. They compared therapeutic anticoagulation, either low molecular weight heparin or IV unfractionated heparin, for a duration of up to 14 days or until recovery, which was defined as hospital discharge or off oxygen for 24 hours. And they compared it against usual care thromboprophylaxis, of which the dose and duration could be determined by the local treating physician, but usually involved either standard low dose or intermediate dose anticoagulation. Their primary outcome was a composite of organ support-free days, which combined in-hospital death and the number of days free of cardiovascular respiratory support, up to 21 days. And again, their primary safety outcome was major bleeding. This was a very large trial, impressive to be done so quickly, including just over 2,200 patients with about 1,100 in each group. Again, they were roughly 60 years old and 60% male, consistent with the prior data we've talked about. Surprisingly, only 60% of patients received steroids, but it was at least equal between groups. Another important thing to note is that of the 80% of patients in the therapeutic arm received therapeutic anticoagulation, so 20% received less than that. Of those who did, 94% of them was low molecular weight heparin, and almost all enoxaparin. In the usual care thromboprophylaxis group, 71% received standard low dose prophylaxis, and 26% received intermediate dose, usually enoxaparin 1 milligram per kilogram daily. As you can see in this table, 80.2% of patients in the therapeutic anticoagulation group survived until hospital discharge without receipt of organ support, while this occurred in 76.4% of patients in the usual care thromboprophylaxis group, for an absolute risk difference of 4 and an odds ratio of 1.2. They stratified their patient groups by D-dimer, with a high D-dimer defined as greater than 2 times the upper limit of normal, and a low D-dimer defined as less than 2 times the upper limit of normal. And you can see here that the benefit of therapeutic anticoagulation is slightly greater in patients in the high D-dimer cohort. Looking at secondary efficacy outcomes, there was a significant reduction in the composite of major thrombotic outcome events or deaths, with more deaths in the prophylactic group, 8% versus 7%. However, the thrombotic events in both groups were quite low, 1.1 and 2% respectively. They also found more major bleeds in the therapeutic anticoagulation group, but this was not statistically significant. The second arm of this multi-platform trial looked at ICU patients, across 121 sites in 9 different countries. Similar definition of ICU level care: high flow nasal prongs, BiPAP, ventilator use, or requiring pressors or inotropes or ECMO. And again, running from April 2020 to November 2020. They had the exact same intervention and comparison, looking at therapeutic heparin versus usual care thromboprophylaxis, and the same primary outcome of organ support-free days. They had just over 1,100 patients, about 550 in each group, similar age to the non-ICU arm at 60 years of age, and a greater percentage of males at 70%. They also had a greater percentage of patients on steroids at 80% compared to 60% in the non-ICU multi-platform trial. They also had, unfortunately, quite a lower rate of treatment adherence, with only 77% of patients randomized to therapeutic anticoagulation. Almost all of these who did receive it received low molecular weight heparin in the form of enoxaparin. In the comparison arm, usual care thromboprophylaxis, about 41% received standard low dose and 51% received intermediate dose. The median value for organ support-free days was 1 in the therapeutic anticoagulation group and 4 in the usual care thromboprophylaxis group, which was a non-significant difference. So certainly a sharp contrast to the treatment benefit they found of therapeutic anticoagulation in hospitalized ward patients. And in fact, in this study, they have found a 95% chance that therapeutic heparin was actually inferior to usual care prophylaxis in ICU patients and resulted in worse treatment outcomes. If you look at the secondary outcomes here, they were found no difference in the composite of major thrombotic events or death. Thrombotic events were numerically higher with usual care thromboprophylaxis and higher overall than in previous studies of ward patients. They also had a numerically higher number of major bleeds in the therapeutic anticoagulation group, but this difference was not statistically significant. The next trial was the RAPID trial, which was a Canadian-based study published in BMJ just recently in October 2021. It included COVID-19 positive patients with an elevated D-dimer who were admitted to hospital wards, not the ICU. They compared therapeutic heparin, either low molecular weight heparin or IV unfractionated heparin, to prophylactic heparin. And it's important to note that in their study protocol, they did not allow any intermediate doses. So this is purely therapeutic heparin versus standard low dose prophylaxis. And treatment was continued until either hospital discharge, day 28, or death, regardless of future ICU admissions. Their primary outcome was similar to previous studies: a composite of ICU admission, the use of non-invasive or invasive mechanical ventilation, and death up to 28 days. And their primary safety outcome was, again, major bleeding. This study was a bit smaller, 465 patients, about 220 in each group, mean age of 60, again, just over 50% male, and about 70% of them were on steroids. They did have excellent treatment adherence, with both groups receiving over 98% of their assigned treatment. It was almost all therapeutic enoxaparin versus prophylactic enoxaparin. This study in ward patients found no statistically significant difference in their primary outcome, again, which was a composite of ICU admission, non-invasive or invasive ventilation, or death at 28 days, with the primary outcome occurring in 16% of patients in therapeutic enoxaparin and 21% in patients receiving prophylactic enoxaparin. However, if we look at the secondary outcomes, they did find quite a large and statistically significant lower rate of all-cause death at 28 days in favor of therapeutic anticoagulation. And you can see the difference here of 1.8% in patients receiving therapeutic enoxaparin versus almost 8% in patients receiving prophylactic enoxaparin. And this difference was not driven by a difference in thrombotic events, as the rates of venous and arterial thromboses were quite low in both groups. In addition, they also found that major bleeding was not different between groups, with actually a numerically higher number of major bleeds in the prophylactic arm. The last trial I wanted to review today is the Hep Covet Trial, published in JAMA, again, quite recently in October 2021. And they included hospitalized patients, both ICU and non-ICU, with elevated D-dimers who were requiring supplementary oxygen within 72 hours of admission. And this took place across multiple sites in the US between May 2020 and May 2021. Their patients were stratified by ICU status, and they defined ICU status as requiring either non-invasive or invasive mechanical ventilation, high-flow nasal prongs, vasopressors, or need for vital monitoring more than every 4 hours. They compared therapeutic enoxaparin. There were no alternatives allowed in terms of the type of low molecular weight heparin, in comparison to standard prophylactic or intermediate dosed heparin, which could either be enoxaparin or unfractionated heparin. Treatment was started at randomization, and the duration was dependent on hospital discharge or an occurrence of the primary efficacy or safety outcome. Of note here, this trial included as part of their protocol that all patients who did not have an efficacy outcome at the time of discharge undergo a screening bilateral leg ultrasound, either on discharge or hospital day 10. Their efficacy outcomes were slightly different, focusing more on thromboses, looking at venous thromboembolism, symptomatic or asymptomatic, arterial thromboembolic events, or death, and less focus on overall survival and ICU outcomes. Their primary safety outcome was also major bleeding. They included a total of 253 patients, so certainly the smallest study we've looked at so far, with about 125 in each group. The mean age was again around 60 to 65, with just over 50% male. 33% of their patients required ICU level care, and 67 were ward only. In terms of study drug adherence, they did not report the adherence for patients randomized to therapeutic anticoagulation. And of the patients who received it, it was all enoxaparin as per their study protocol. In the comparison group, the 61% of patients received standard low-dose prophylaxis, and 39% received intermediate dose anticoagulation. The primary efficacy outcome across the whole study population, which was a composite of venous thrombosis, arterial thrombosis, and all-cause death, was significantly lower in patients randomized to therapeutic enoxaparin as compared to standard or intermediate dose anticoagulation. You can see here about 42% in the standard prophylaxis group versus 28% in the therapeutic enoxaparin. But when they compared this outcome by level of care required, we can see that there was only a benefit of therapeutic anticoagulation in patients who did not require ICU, and that there was no benefit in patients who did require ICU care. This overall benefit of therapeutic anticoagulation was primarily driven by a reduction in thrombotic events, with almost 3 times as many thrombotic events occurring in patients who received only prophylaxis, and almost all of these were venous thromboses. As we can see, the death rates were actually quite similar, 19% in the therapeutic group, 25% in the standard group, and not statistically significant. In terms of bleeding, there were more bleeds with therapeutic anticoagulation, particularly in the ICU group, but none of these differences were statistically significant. We've now covered all the major thromboprophylaxis trials in COVID-19, and there's been a lot of numbers and a lot of tables. But fortunately, the authors of the RAPID trial went on to perform a meta-analysis of all these RCTs to help shed some more clarity on the overall picture, and I find it helpful to help synthesize the data that we've already discussed. This meta-analysis was published also recently in October of this past year, and they included any randomized controlled trial that compared therapeutic dosed heparin with usual care thromboprophylaxis. And this could either be standard low dose or intermediate dose in both ward and ICU patients. They excluded randomized controlled trials that use anticoagulation, therefore excluding the ACTION trial with rivaroxaban, and they excluded randomized controlled trials that used intermediate dose anticoagulation as the experimental arm, therefore excluding the INSPIRATION trial that we've discussed. If we look first at moderate illness or ward patients, therapeutic anticoagulation versus usual care thromboprophylaxis, either intermediate dose or standard low dose, resulted in a non-significant reduction in all-cause death, a significant reduction in various composite outcomes, including death and invasive ventilation, death or organ support, death or major thrombotic events. They also found a significant reduction in major thrombotic events and a non-significant increase in major bleeding. So certainly good evidence that therapeutic anticoagulation in patients with moderate disease or ward patients is beneficial over prophylaxis. In contrast, therapeutic anticoagulation versus prophylaxis in ICU patients demonstrated no difference in both all-cause death or any composite outcome of death or thrombotic events. They found a significant reduction in major thrombotic events alone and a non-significant increase in major bleeding. This graph here shows their analysis of the interaction between treatment effect and severity of illness. We can see that there was evidence of benefit for therapeutic anticoagulation for moderately ill ward patients with reduced all-cause death in major thrombotic event, and death in any thrombotic event, but that there was no benefit in any of these outcomes for therapeutic anticoagulation in severely ill ICU patients, in keeping with the previous figures we've just looked at. However, in both ward and ICU patients, therapeutic anticoagulation had a significant reduction in major thrombotic events and a non-significant increase in major bleeding, and this was regardless of disease severity. I personally find this graph very interesting because it highlights the disconnect that we've seen between the observed benefits of therapeutic heparin in COVID-19 patients and the known benefits or adverse effects of heparins in general. And by this, I mean that we can see that therapeutic anticoagulation is doing its job in reducing major thrombotic events and does cause some increased bleeding, regardless of ICU or ward status. But through some other mechanism, heparins are benefiting ward level patients and non-ICU level patients in terms of overall mortality. And throughout the literature, there have been a number of mechanisms postulated for this disconnect, and they're primarily centered on the potential anti-inflammatory and antiviral effects of heparin. But heparins have previously never been shown to be effective, to be an effective agent in other forms of ARDS or viral sepsis, which to me certainly does shed some questions on these overall findings because we don't fully understand the mechanisms of benefit, but we have on now repeated multiple large randomized controlled trials demonstrated that therapeutic anticoagulation, particularly heparin, does seem to benefit ward level patients and not ICU level patients. Based on the data that we've just reviewed, the American Society of Hematology, or ASH, updated their guidelines for thromboprophylaxis in patients admitted with COVID-19 in February 2022. For ICU patients, they suggest prophylactic anticoagulation over therapeutic or intermediate anticoagulation. And for ward patients, so moderate disease, non-ICU level care, they suggest therapeutic anticoagulation over prophylactic or intermediate anticoagulation, unless these patients are at high risk of bleeding. And similarly, the BC CDC just recently this month updated their recommendations, and they're a bit more directive than the ASH guidelines. For ICU patients, they recommend prophylactic low molecular weight heparin, and in ward patients, they state that therapeutic anticoagulation, preferably low molecular weight heparin, can be considered in patients without high-risk features for serious bleeding, which include age over 75, GFR less than 70, coagulopathy, platelets less than 50, use of dual antiplatelet therapy, or recent GI bleed or CNS pathology. They also go on to state that in patients who decompensate while on therapeutic anticoagulation and require subsequent ICU admission, that therapeutic anticoagulation should be continued for up to 14 days. And a lot of this is in keeping with the protocols from the large multi-platform trials, which certainly represent the best body of evidence that we have so far. So in summary, we've discussed the BC COVID experience through the caveat study from January to December 2020. And as a reminder, there were 565 patients. The vast majority of them were on the ward, mostly received intermediate or low dose prophylaxis. 14% of patients in BC during that time died. 4% had venous thromboembolism, and 4.6% had a major bleeding rate. And if we look back over the numbers in the various randomized controlled trials we discussed, these numbers are slightly higher than in some of the studies. And I do wonder whether this is partly because we track patients for a longer period of time than the 2 weeks or 30 days in the randomized controlled trials. We also found a low rate of post-discharge VTE. We've also discussed the optimal thromboprophylaxis for COVID-19 hospitalized patients, and it's quite challenging. We have a growing body of evidence with a number of recent large randomized controlled trials, and the general trend seems to be that in ICU patients, therapeutic anticoagulation appears not to be beneficial and perhaps even detrimental, whereas in ward patients, therapeutic anticoagulation appears to be beneficial over prophylaxis. However, the mechanism of this benefit remains unclear, and certainly further studies are in the works and will hopefully clarify this process. As both patient groups, both ICU and ward, experience lower rates of thrombosis with therapeutic anticoagulation, but do not achieve similar benefits in mortality. In current guidelines, both international and local here in BC, are currently recommending that ICU patients receive thromboprophylaxis alone, and that ward patients receive therapeutic anticoagulation unless they are deemed at high risk of bleeding. Thank you.
Thank you very much for that great presentation. And before I open it up to questions, and I'm sure comments, I just wanted to ask, with these findings, would this change the approach to patients who have active inflammatory disease admitted to the CTU that don't have COVID? Since now we use prophylactic heparin, is there any study that's looking at using therapeutic heparin for these patients?
It's certainly a good question. I'm not aware myself of any trials that have looked at that, but as I alluded to earlier, this benefit of therapeutic heparin in COVID-19 is the mechanism is certainly hard to explain. You know, they have looked at it they have looked at using therapeutic anticoagulation, unfractionated heparin or low molecular weight heparin in ARDS and other forms of viral sepsis and that type of clinical picture. Obviously not to the same degree with so many large trials as we have in COVID, but it's never previously been shown to be effective. And so it definitely is hard to explain why we see a benefit of therapeutic heparin in COVID patients on the ward. And so I personally would be hesitant to extrapolate that to ward patients with a similar, significant inflammatory response, but without COVID, just because I'm not fully convinced that we know the mechanism enough to make that jump. That would be at least my thought.
Good, thank you. Open it up to questions, comments. So Dr. Tothill says, what parameters would you use to determine ward patients who should receive therapeutic anticoagulation?
Yeah, certainly an excellent question. I mean, if you go by the, purely by the data that we have, the formal inclusion criteria, anyone at high risk of bleeding, certainly. By the randomized trial data, it would be, anyone who is admitted to hospital on the ward only with COVID-19. I would say myself, personally, I would have a very low threshold to not use therapeutic anticoagulation in ward patients with COVID. I would have to be very convinced that they were not at high risk of bleeding. So if anyone who is, even slightly old and has some other comorbidities I would worry about, any sort of renal dysfunction, then I would definitely quickly jump to using standard prophylaxis. That being said, I'm sure there are, that percentage of patients who are otherwise young and not overly comorbid, they might certainly benefit from therapeutic anticoagulation, as we've seen in the studies. But again, I always get personally uncomfortable when the mechanism of benefit is unclear, but certainly the data that we've reviewed is supportive of using therapeutic anticoagulation in ward patients.
So Dr. Emily Lai asks, is there any information regarding microvascular thrombi? Sorry, that's the wrong word. Dr. Lai asks, pardon me, I lost the thread of that. Oh, do you think these recommendations are different with Omicron? That was her question.
Oh, that is a good question. I certainly don't know myself whether, all the studies, this growing body of evidence that we have, all of it started in the spring or summer of 2020, and most of it ended by this past fall. And so they probably captured some of the patients with Omicron, but not to the same extent as if a trial had been started more recently. And so, the short answer is I don't know. Definitely from, Omicron seems to be less, has less of an impact on the lungs, and then perhaps the benefit of therapeutic anticoagulation, you could infer would be less beneficial. But again, now I'm really extrapolating and guessing. So I'm not sure is the short answer.
Thank you. And Dr. Werb asks, is there any information regarding microvascular thrombi?
I mean, in terms of, just so I understand the question, in terms of a benefit of anticoagulation, specifically in terms of microvascular thrombi, like does that and that's impact? Is that the question?
I'm just reading it in the chat. So, Dr.
Okay.
You're available to clarify. That's what the chat was asking.
Okay. I'm not sure. I mean, certainly they, early on in the pandemic, in a lot of small autopsy studies, they found, quite marked increases in microvascular thrombi and, in multiple organ beds in severe patients with COVID-19. How that translates to the clinical outcomes in COVID patients from these studies, I'm not sure. I mean, it's the overall rates of thrombosis certainly in the ward patients from these large trials is surprisingly low, and similarly the rates of arterial thrombosis is very low, and definitely in sharp contrast to the early data that came out at the very start of the pandemic, where, as we talked about, it was about 25-30% of patients developing blood clots and a high signal of increased risk of stroke and other arterial events that we don't really see to the same extent when they studied it in the large randomized controlled trials. So I don't know whether that is a result of reduced microvascular thrombi or how that impacts it. So I'm not sure if I answered that question appropriately.
And Dr. Gorman asks, in patients with an alternate indication for anticoagulation, say AFib, who are then admitted to the ward with moderate COVID, how do you manage their anticoagulation?
So if they had my approach would be if they had an indication for therapeutic anticoagulation and they now contract COVID and are admitted to a ward, not the ICU. If they didn't have major risk factors for bleeding, then I would certainly continue them on therapeutic anticoagulation. I would definitely give them a type of heparin and not, if they were on a DOAC at home, I would switch that. But if they were admitted from home to the ICU for symptomatic severe COVID, then I would give them prophylaxis up front, unless, just like any patient, unless you were significantly concerned about their risk for AFib or recurrent PE or whatever their indication for baseline anticoagulation would be.
And Dr. Kim asks, were there any vaccination status reported from these studies? Would any of these recommendations change based on vaccination status?
Yeah, that's a good question. None of the studies in any of their supplemental appendices or adjunct data they published reported COVID vaccination status. That certainly would be an interesting factor. I would guess that the results would be unchanged. If the vaccine, if you had the vaccine and you then contracted COVID to the point that you required, either admission to the ward or admission to the ICU, I still feel that the treatments the non-anticoagulation treatments you receive in hospital would be the same, and so I would use the same approach with anticoagulation as I would without knowing your vaccination status.
I think I've run through the chat. I have another question, and maybe you've addressed it and I missed it. Is that you mentioned the enoxaparin is the low molecular weight heparin that's preferred. Are there any trials using other forms of low molecular weight heparin, or is this just information because that was what was used?
Yeah, it's more so. There were a few trials that in their protocol only allowed enoxaparin, but the majority of them allowed any form of low molecular weight heparin. It just happened that at whatever centers were included in the study, they more commonly use enoxaparin. So certainly the overall body of evidence is more supportive of enoxaparin, but that's mainly by virtue of its increased frequency of use. And there haven't been any trials that enoxaparin was not the most dominant low molecular weight heparin used. That being said, I myself would apply that interchangeably to dalteparin and tinzaparin, just because we know that they are similarly effective in other indications for anticoagulation. There's some changes with renal function that you have to consider, but otherwise I myself at least would apply them interchangeably. But certainly the greatest body of evidence overall is for enoxaparin, both at the high dose and the low dose.
And Dr. Ra here, I hope I pronounced that correctly, asks, is Enox 30 milligrams sub-Q BID considered low dose prophylaxis or intermediate?
That's considered intermediate dose prophylaxis. So for right now, based on these studies and the new guidelines based on this information, there's really no role for intermediate dosed thromboprophylaxis. So it's either you would decide to use full therapeutic dosed anticoagulation in hospitalized ward patients who are at low risk of bleeding, or in everyone else high risk of bleeding or admitted to the ICU, you would just use prophylaxis as it stands now.
Thank you. I don't have any more questions in the chat box. Does anybody have other questions or comments they wanted to ask Dr. Taylor or comment to Dr. Taylor? If not, I'll just pass on the thank you from the entire staff. Dr. Palapu in the chat box commented on the exceptional grand rounds, and I would certainly second that. And I think the only challenge will be to perform again at this level. So thank you very much for presenting Grand Rounds. And next week, before I leave, just to let you know, Dr. Belga from the VGH Division of Infectious Diseases is going to talk on challenges and insights of CMV in transplantation. So thank you again. That was an excellent Grand Round.
Thank you very much. It was an honor. I hope everyone has a good rest of the day. Thank you very much.